All right, so good evening, everyone. Well, welcome to this webinar. Hope you've had a great day today. Social norms webinar. So today, we'll be looking at intersection matters, how social norms, that is gender and faith norms, normalize corruption in Nigeria's primary healthcare system. So before we go ahead this evening, I'll introduce myself, and also members of the research team would also introduce themselves. So my name is S.A. Adams, and I work with the Policy Innovation Center. Good to be here this evening, and I'm also glad to see everyone here. Yeah, the names are dropping already, introducing yourselves, that's good. So I will just allow members of the team to quickly introduce themselves, and then we'll kick off for today. So we can start with Diane. Quickly introduce yourself.
Hi, everybody. Nice to see people introducing themselves in the chat. My name is Diana Chigas. I'm the co-director of the Corruption, Justice, and Legitimacy program at Basic Global, and we've been partnering with PIC on this research.
Okay, welcome, Diane. Cheyenne.
Thank you. Lovely to meet everyone. My name is Cheyenne Church. I'm the head of Basic Global, and really looking forward to this conversation.
All right, welcome. Mayoko.
Good day, everyone. My name is Mayoko Adejono. I work with the PIC. I'm happy to be here. Thank you.
Welcome, Isaac.
I'm Sobun from the Policy Innovation Center as well. Nice to be here. Thank you.
Hi, everyone. My name is Busola Oni. I work with the Policy Innovation Center. Nice to be here.
Okay, so we are all welcome. So quickly, so that we don't take too much of your time. So, talking about this research, some of the research questions that are on our mind, that took us to the field and, bring out these interesting findings. Some of them are, looking at corruption in Nigeria and seeing how it permeates our political, economical, and social institutions, So we decided to look at these research questions for this particular study. And these are the questions. How do gender and faith norms intersect with social norms that drive corrupt practices of unauthorized charges for free vaccines and commodities in the health sector in Nigeria? And what are the norms or expectations influencing health workers as well as users' behavior in relation to demand and payment of unauthorized charges for free vaccines and health commodities? And also wanted to look at how do gender and religion influence or change the behaviors of men, women, or people of different religions in making unauthorized charges or paying unauthorized charges. Okay, so we needed to answer these questions, to really understand, how these different norms, they intersect, and by that intersection, how they influence corrupt behaviors. And looking at this intersection, we believe that if we're able to answer these questions, looking at that intersection, we believe that anti-corruption programmers will be able to adapt them, in their programming activities. We needed to understand how norms, based on different identities, specifically gender and faith norms, how they intersect with social norms to influence the practice of informal payments for health commodities and vaccines in Nigeria. I know some of us will be wondering, what are social norms? What are gender norms? What are faith norms? Don't worry, you are all going to get a good understanding of it. So without much ado, I'll be handing over to Cheyenne, to take us through what are social norms, what are gender norms, what are faith norms. Thank you.
Thank you, and thanks everyone for joining us. What a terrific turnout from people with clearly tremendous amounts of experience and expertise in this issue. So my name's Cheyenne Church, and I'm the executive director of Basic Global. And our organization works with partners to fight the corruption that blocks really important development and peace building outcomes. And today's webinar is just such a delight to be participating in, because the spark of this research actually came from two projects that I was involved in years and years ago, before COVID. The first was in the DRC, where we were working with female judges around issues of corruption within the judiciary. And they explained to us how if they were caught in a corruption scandal, the consequences would be so much greater personally for them than for their male colleagues. And this, of course, had all sorts of impacts on their behavior. And simultaneously, we were working in the Central African Republic, where we were finding different behaviors related to corruption and the judiciary between the Christian and the Muslim communities. And as Diana and I reflected on these differences, we started to ask ourselves, if we used a lens of social norms to understand these differences, what might it tell us? So in other words, are there gender norms or faith norms that were dictating these different behaviors when it came to corrupt practices? And if there were gender or faith norms that were driving these different behaviors, what would we have to do differently in order to then go ahead and change those behaviors? And all of those questions led to this research, Intersection Matters, How Social and Gender and Faith Norms Normalize Corruption in Nigeria's Primary Healthcare System. I'm assuming everyone can see now a slide, and if not, I'm hoping someone will let me know. Before we dive into the answers that we have found for this question, let me just say a few words about social norms. And I'm aware that a lot of people in this call are really knowledgeable already about social norms, but for the few who might be new, I just wanted to give it 2 minutes of time. So social norms are the unwritten rules that guide behavior. Think of them kind of like mutual expectations that are held within the members of a group about the right way to behave. And if you don't follow those unwritten rules, if you don't behave in the right way, you're going to face consequences from the same group. So when we say gender norm, for instance, what we're meaning is the unwritten rule that guides men and women's behavior. Similarly, when we say faith norm, we mean the unwritten rule that guides the behavior of that particular faith community. Now, norms are made up of two different sets of perceptions or beliefs. The first, shown on the left side here, are what are often called descriptive norms. And descriptive norms are what I believe other people do in a particular situation. I always use the D in descriptive with the D in do to remember that. So a descriptive norm are what I believe other people do in a particular situation. So let's pretend I'm a civil servant in a passport office. Do I believe that other staff in the passport office require citizens to pay an illegal fee in order to have their passport application granted? And if I believe that, then that is the descriptive norm. The second set of perceptions that make up norms, it's a little bit more complicated, and these are called injunctive norms. And these are what I think other people think I should be doing in this particular situation. So if we go back to our passport example, what do I think other staff in this office think I should be doing when a citizen applies for a passport? Do I think the other staff think I should be charging a fee? Or do I think the other staff think I should just be processing it according to the official rules and framework? Now, when we're forming these beliefs of what other people do and what other people think I should do, these other people aren't just any old person on the street, typically. It's really about people we care about in the particular situation. It's this group, which is often called the reference group. And it's this reference group who are going to enact your positive and your negative consequences if you break the unwritten rule. Now, these consequences, what we typically find when you break an unwritten rule, are going to occur in either around your reputation or around your relationship with the other people in the group. So if you do not follow an unwritten rule. You might become the subject of some pretty negative, nasty gossip. You might be seen as somebody who's trustworthy and people are acting like you're a little bit of a suspicious character. And you might be starting to get the cold shoulder where you're being excluded from the group, from lunch, from invitations, from little interactions and connections to show that you're no longer one of us. Similarly, though, this is also the groups that's going to reward you if you adhere to the expectations of how to behave. And so you're going to be rewarded in the form of acceptance, celebrated, acknowledgements, and tighter connections within the group. So if norms are the unwritten rules that guide behaviors within a group, then we should also briefly touch on what social norms are not. So I'm going to touch on two very quickly. Social norms are not the same as individual attitudes. An individual attitude is about what I believe is right or wrong. And this really matters because I can dislike something, but still do it because the social norm is so strong. So for instance, I can dislike asking for an illegal fee in the passport office, if we go back to that example, but I can still do it because I feel such expectation from the other staff within that passport office. So social norms are the expectations. They're not the same as an individual attitude. Next one I want to flag. Social norms are not the same as behaviors that are commonly done because those behaviors meet a need or answer a problem for a person. So I use an umbrella, and lots of people use an umbrella in the rain. I wear sunglasses when driving in bright sunlight, as do lots and lots of people. Those are common behaviors, but they're not driven by a social norm because there's no consequence in terms of social sanctions, rewards, and punishments if I elect not to do it. And we have to keep these distinctions in mind because how we would change something that's a convention, meaning something that happens regularly, but it's not driven by a social norm, and how to change something that's driven by a social norm are quite different. So when we get to the end point of thinking around programming, understanding what we're dealing with, be it an attitude, a social norm, a convention, that really becomes important when coming up with strategies. Finally, before I pass it over and we really get into answering the questions, I think there's a couple of really important acknowledgements that I would like to make. First off, I want to thank the On Nigeria team from the MacArthur Foundation. Not only did they provide the financial support for this work, they were a flexible and responsive partner throughout the entire process. And we just really wanted to acknowledge and appreciate that. We also think it's just essential to acknowledge and thank the Policy Innovation Center team. Their dedication and hard work was notable. This was really a big piece of research, and not every team could have gotten across the finish line like this team did. So thank you for your excellent work. And with that, I have the privilege to hand it over to Isaac, who is a senior research advisor at the Policy Innovation Center. Isaac played a pivotal role in the research as the coordinator of all the fieldwork.
Thank you so much, Cheyenne. Hello, everyone. Nice to be here, and we're glad that we're sharing the exciting work we did on this social norm project. While we're introducing ourselves as members, I think we skipped Paul. So I'll just want Paul to quickly introduce himself. Hi, Paul, can you hear me?
Hello, my name is Paul Okorochi, a professor at McArthur University, School of Social Sciences, and I was part of the research team along with the Aloysius Nyombi, who is here. Thank you very much.
Thank you so much, Paul. And thank you, everyone, again. So we'll go straight to the methodology. For this study, we had a 4-phase methodology process where we started with the behaviors, selecting the behaviors and sectors. So when we started, we set out to sort of explore all the areas so that we're not just deciding where we want to work in. So we held statements forum here in Abuja, where we had players from the agri sector, the education sector, and as well as the humanitarian section. After that conversation, we're so sure that it was very important to delve deeply into the health sector and specifically primary healthcare sector. With that, we're able to initially generate some behaviors of interest for health workers and service users. Now you'll be hearing these terms as this conversation go on. So let me just explain them. Health workers are generally the staffs in the healthcare sector. So you hear doctors, nurses, lab technicians, and the rest of them, extension workers, health extension workers, and the rest of them. While service users are anyone who comes to the health facility to seek health services. So after that initial phase of the behavioral selection and all of that, straight to the study approach where we first selected 3 states. One, a predominantly Muslim state, which was Kano, based on the NBS data, a predominantly Christian state, Ebonyi, and then a mixed state, Nasarawa. Of course, we also relied on other criteria like safety and access to these states. So with that, we were able to conduct OGD and KII with participants across these states in primary healthcare centers, selecting 2 local governments, one urban and another rural. After that, we conducted analysis and then went straight into the sense-making workshop. Sense-making workshop was an opportunity to validate our findings in each of those states and do some form of member checking. After that, because one of the study is to be able to use the findings of this study in programming, we were able to conduct a certification workshop where we pulled players, practitioners in the anti-corruption space, government officials, the academia, and sit down for a whole day to discuss the findings and see how these findings will play into their day-to-day programming for anti-corruption. That was what the study was like for us, and it was an interesting journey. We'll go straight into deep diving into the findings of the study. And I would start that by first introducing, of course, we've met her earlier, Busola Oni, who supported in the work as well. So Busola, the research found that informal payments are white and normalized. And even though at the same time, the users believe that this is wrong, and then the providers also believe that this is wrong, yet they engage in these practices. Why does this double reality exist where people know that, oh, informal payment is wrong, but they still practice it?
Okay, thank you for that question. So, in our research, while we found that social norms play a significant role, there are also key non-normative drivers that we found that were interacting with these norms to create what you've called a double reality for systemic corruption in the healthcare system, especially in primary healthcare like we researched. First, we found that there were weak institutional accountability. That stood out for us, especially in a place like Ebonyi and Kano State. And with no credible systems for monitoring, reporting, and sanctioning informal transactions or payments, health workers especially who are like they have the power, they often feel emboldened to engage in informal payments because obviously no one is watching, and even when someone is watching, they've probably greased the person's hand, and obviously person will just keep quiet and just allow the practice to continue. Another thing that we found out was the influence of economic uncertainty, especially among health workers they have expectations outside the facility, like we'll be discussing later on in the webinar. And then many of them operate in underfunded systems. We saw them complaining of insufficient resources, um, irregular salaries or delayed, and this creates like a structural vulnerability that informal payments exploit because even when you say, oh, there's a salary that is coming, it can't even be sufficient for the family till the month ends, and it's just a way of just looking for other means to get additional income, more like, oh, something extra. Where I work is where I will eat. So this is where this sort of perpetuates informal payments in the primary healthcare centers, because they feel like, oh, the salaries that the government are paying us are not enough, and possibly their family members might even just, they wouldn't want to even know that, oh, they are not being paid well. They'll just assume that, oh, so far you are a health worker, you are earning well, you are even a government worker, and they just assume. And this creates a kind of pressure, which I believe my other colleagues will also be discussing more. Thirdly, we found inadequate transparency, because in most health centers, people, and by people here I mean the service users who are the receiving end, they don't even know the services that are formally free or the ones that are paid for. So this
Mm,
opacity, it has created a sort of fertile ground for informal payment to thrive, because you don't even know which payments, which services should be free and the ones that are meant to be paid for. So with that, the health workers can
mm,
now ride on that to frame informal payments as legitimate, because obviously, especially for women, we found that with female service users, they don't have that autonomy, they don't have that bureaucratic knowledge to even like, oh, is this actually supposed to be paid for? For instance, I took my child to vaccine for vaccination, and I don't even know that it's actually meant to be free. But the health worker who already know that, oh,
yeah.
you don't know about this, they will just ride on that lack of knowledge. Also, but one thing was really shocking, because we saw in a place like Nasarawa State, whereby there were measures in place for accountability, for monitoring, for evaluation. We saw that, oh, they were actually, you will see that cases where people will say, oh, they actually monitor us. The WDCs in these facilities, they are very strong, and you can't just do anything.
Mm,
But even in those cases, even in those seemingly better places, we see some cases where
this is, yeah.
informal payments still thrived, still persist. Because in that case,
Mm,
health workers will still find a way to now more or less like nudge the behavior, nudge the norm in a different light, and
mm,
say, oh, it's for facility maintenance, or they rather not ask it openly like they would in places like Ebonyi or Kano. They might now like ask
yeah.
it in, they might be asking it hiddenly. Some of them would even use volunteers, because we have cases where, of course, we know that most primary healthcare centers, they don't even have enough staff. So they usually have volunteers that are not actual staffs, but they will be the ones to like be at the forefront. That obviously the people know that they don't pay volunteers normally, so they'll just ride on that fact that, oh, we have to collect this, we have to collect this little payment. But the truth is that most of these payments are going to be remitted to the actual staff, the full-time staff, because they were the one that sent them. Obviously, volunteers can't even go ahead to start charging informal payments without being authorized by a supervisor or a health worker who is like a full-time staff in the facility. So that's like a double reality, whereby even though people were justifying the fact that, oh, a service users will say, oh, it's because there are no accountability measures, there are no monitoring systems. Health workers will say, oh,
Mm,
the salaries are low,
okay.
the facility is underfunded. But we see some cases where it will still thrive even when informal payments will still persist even when these measures are in place. So that's just like a kind of
Yeah.
issue that we found out on the field. That, okay, so you are telling us that even when Nigeria becomes better, like everyone is praying for, it's still very possible that these issues, these corrupt practices would still continue, will still persist.
Something.
And then we now wonder
Yeah.
what then is the way forward. So in essence, wanting
Yeah.
to close, I would just say corruption in this context isn't about bad people doing bad things. It's like
Mm,
an ecosystem
mm.
of institutional weaknesses, socioeconomic stressors, converging to normalize and perpetuate informal payments. Thank you.
Thank you so much for that, Bisola. Thank you for speaking to the fact that even though both health workers and service users see this as wrong, they still engage in these practices. And you made us understand some of the structural and behavioral drivers that affect this. Now, speaking
Yes.
strictly on the service user, and I would be pointing to Melco now. In the report, am I mentioned that the link to the report is on the chat box, so we can just go there while we're listening and download the report. It's a very interesting read. So in the report, one service user said something like, I don't like it, but I just have to pay. And that's talking about the informal payment or unauthorized charges. Why do service users accept to pay or offer these informal charges, despite knowing that they either do not like it or they don't want to do it? Michael.
All right, thank you so much. Thank you everyone for joining. My name is Mayoko. Just like my colleague Adelia mentioned, that we had like various reasons why service users would want to be compelled to either give informal payments or probably accept to pay informal payments. So and just like you said earlier, we had like a wide range of behaviors that we explored, and one of them is the fact that service users offer and accept to pay informal payment at the facility. Now, one of the key things that we found strongly was that most service users acknowledged that informal payments were unethical and morally inappropriate, but they still chose to either offer or accept to pay informal payments as a coping mechanism, right? But one of the key reasons why service users follow through with this behavior is the fact that for practical reasons, right? I will give you an instance. Typically the Nigerian healthcare system is complex to navigate and it takes time to access care. So, and this is especially true for vulnerable groups, right? And one of the things they found out is if you want to simplify the complexity of the Nigerian healthcare system, either to reduce the wait time, expedite access to services, or have quality service, you have to be practical, which means that you have to think of finding your way through. And one of the things they found is to either offer and or accept to pay informal payment, right? So usually failure of service users to comply with this again would now mean that it will come with sanctions, for instance, delayed treatment, delayed access to care, or they are sidelined or they are punished and all of that. But now, of course, there's a gender and faith dimension to this, which I think we would talk about later on. Thank you.
Thank you so much. Thank you so much. And we also further reinforces the cycle of payments, because you find women who come for, say, antenatal or antenatal care, say something like, oh, that's how it's done here, so we have to just continue. We cannot stop it. And that also speaks a lot to agency. But let's speak about the health workers. We also found out that health workers typically ask for these payments or accept when offered. And part of the reason we had also highlighted earlier was structural reasons like low salaries, underfunding, shortages of supply. Now we found where they felt like, oh, we're doing you a favor, so we want to use this money you're giving us, although it's unauthorized, to go get these things. I want to ask, what did you learn about social norms that drive these behaviors, and how do gender and faith norms play out concerning this behavior?
All right. Thank you so much. I'll be speaking on the component of the health workers now. So the behavior that we explored with health workers. So we wanted to know if health workers solicit and accept informal payment from service users, and our findings showed that there were mutual expectations that drive and sustain health workers in engaging in informal practices. And these shared expectations are within the health facilities and also in the communities. So that's to tell you that there are both direct and indirect mutual social expectations that drove health workers to solicit or accept informal payment from service users. So I will start with the direct social expectation that happen within the facility. So there is a direct shared expectation from health workers as a facility to have for informal payment from service users, and this norm is sustained by positive sanctions for compliance and negative sanctions for non-compliance. And that's how we got to know that, of course, there is an element of social norms driving this behavior. So health workers who comply are in good books of their colleagues, and the ones who don't comply are either ostracized, ridiculed by superiors and colleagues. So they will be labeled as difficult by colleagues who probably depend on this extra income stream, right? So, and that's what happens in the facility. Now, there is also another social expectation that, of course, drive this behavior within the community. So there is an indirect shared expectation from family members, community members, for health workers to meet financial obligations due to their perceived elevated status as individuals who are financially buoyant in the community. So they're often expected to give generously at home and also in the communities. So for so many of these health workers asking for IP, it is one of the ways, like asking for informal payment is one of the ways to implicitly meet these obligations. And that's the reason why I called it indirect social expectation. Of course, from the community, they won't tell you that you have to ask for informal payment before you are able to meet for you to meet this financial obligations in the community and at home. But then they, in their own wisdom, devised this way to say that, well, the financial obligation is huge and expectation is huge from communities and from family members. I think this is one of the surest ways by which I can do that, right? And of course, there are positive and negative sanctions from the community, that sustain this behavior. For instance, health workers who have enough money, right, apparently by complying to probably asking for informal payment, are seen as somebody of elevated status, somebody of respect. Why? Because they are meeting some of these financial obligations both at home and in the community. Now, talking about how gender and faith norms shape these dynamics. So at the facility level, so I'll start with, of course, the fact that gender and faith dynamics add another layer of complexity to this behavior, right? They make it more compelling to conform to this behavior. For instance, let's look at a gender norm that expects male health workers, to probably have more money, right? Both at home and also in the community. So health workers like this experience more pressure to comply to this behavior because of the gender role placed on them as breadwinners, household heads, with the expectation that they provide adequate financial support for their family, right? And failure to do that would come with sanctions, right, from the society. You are irresponsible, right? Again, if you look at it, one other thing, component that drives, or gender role that drives male health worker to do this more, to engage in this behavior more, is the fact that they are seen as bolder, right? So, and that's the reason why we saw that male health workers are even bolder in asking for informal payment. And this comes with minimal sanctions simply because they are fulfilling their gender role of being assertive, right? Let's look at the component of female health workers. They engage in this practice as much as men, and we found that in our study. But they provide justification, that this is for greater good, and engage in this practice more discreetly, simply because of the fact that a female is expected to be kind, to be honest, to be caring, right? So you would see that there's this conflicting norm, right, that probably, would want female to be more careful when it comes to engaging in informal payment. But this dynamic is actually changing. For instance, we found in a Boeing that some female health workers are increasingly taking on gender roles, also providers, right? Against the previously held norms that they are less likely to engage in economic participation at household level. And this increases their, the pressure, right, for them to be able to participate in informal payment. So this is giving women the body of bearing dual responsibilities of income generation and caregiving, roles, right? And this increases the financial pressure they face when it comes to, conforming to this behavior, right? So women face conflicting expectations, just as we compare to, men, right? For instance, the gender expectation of being honest, caring, with the, social expectation to ask and accept informal payment. So there's a conflict between, when you look at, you're supposed to be caring as a woman and honest. So you are not supposed to collect informal payment. But then there's also a social expectation that happens within the facility that compels them to do this, right? And all of this come
Yes.
with different negative sanctions, more for women, right? Because you have norms or social expectations that are more um, synergistic for men compared to women, right? For women, you have many more that are conflicting. And, women have actually found ways to really adapt. But before that, again, for men, you look at this conflicting norm that, there's this religious teaching that you have to be, that discourages corruption or greed, right, in the community.
Yeah.
But then it is the same
Mm.
community, maybe for instance, religious leaders that expect them to contribute generously, to activities, social activities in the community. And you see this, conflicting norms, these expectations conflicting each other. And that's the reason why most of the times health workers have found ways to adapt, to this, right? So as I mentioned, what they do is
Mm.
when they face conflicting norms, is that some of them, resolve this not by refraining from informal payment, but they found subtle ways, right, of asking. Some will tell you that, oh, so this is not just about it. They will say, is there anything that you can give us, just an appreciation of what we have done? Some actually would, indirectly and subtly ask for this, modestly, so that. But
Mm.
the truth of the matter is that this behavior continues. But it's only that, female health workers, male health workers have found uh, unique ways of actually engaging in this behavior. Thank you.
Thank you so much, Malcolm. That was quite explanatory. And just to also mention, we have a link to the report and a link to a blog that we wrote that speaks to sort of what Malcolm was talking about. Also, Malcolm highlighted something about what we termed as the gender double bind. And that's because the role or the social expectations on women is gradually evolving. And that means that women are no longer expected to just be household items, as it were, or just stay at home and take care of the family and all of that. There's also the pressure of going out there to also source money for the family upkeep. So that means that the need to go out of their way to make extra money just so that the family can just continue to survive is also on them. So there's also that double pressure of being a good housewife and then engaging in all of these things. However, I just have two more questions for you, Malcolm. But before that, you mentioned something about appreciation. And we often heard that, oh, it's not a bribe, it's just an appreciation. And there was also the culture of you don't say no to gifts, you do not appreciation. Can you say more about what appreciation is and how the culture of framing appreciation made it more difficult to address the issue of corruption in the primary healthcare system?
All right. Thank you. Thank you so much. So from our study, so to them, both health workers and service users, a token of gift is given after care, not before or during rendering services, right? So for them, they framed it as, okay, this is voluntary gift from, maybe a service user who probably appreciate what you have done for them in the course of receiving care from them. And it's not a demand um, from health workers, right? But then, of course, we would see that there is subtle social expectation, even from health workers, right? Uh, and also from health workers in particular, for them to, receive this gift from service users. So service users are mostly pressured to give some of these so-called appreciation or gift, after they've actually received service. And this there's also a social expectation from the community that also backs, this behavior, right? Most especially when they see that, oh, you are a big man, you are somebody, an individual of elevated status in the community. So they immediately label you as being stingy if you go otherwise, right? If, for instance, you just received care and then they ensure that you received quality care. And after receiving that care, you failed to probably appreciate them. Some health workers will be able to say, Oga, are you not going to drop something for your boys? Or some the community members would, probably gossip about you to say that, this guy is very stingy and all of that, right? Also, of course, there is also in place a place like Kano State, or of course, religious expectation towards that, right? If, for instance, you're a leader, a religious leader, you're expected to probably give, after receiving care. And this is they have a terminology for this. That's when you are being generous, and it's for them. It's part of their religious precept for you to be able to do that. So once you do that, of course, you are. So I mean, you're a good person, right? And this makes it a bit challenging to know what is unethical and what is ethical when it comes to informal payment, right? So the impact of it has a great impact when it comes to addressing corruption. There's a blurred line between gifts and payment, right? It's harder to challenge, to know when somebody is actually giving you a gift and then there's no motive behind it, right? For instance, if I'm doing this, I'm wetting the ground. In the future, I'll be able to get preferential treatment from this person. And also, what makes it a bit hard is that it shields health workers from being accountable, right? Of course, when they're asking you directly, they will tell you that, oh, this person gave me this gift out of his own, out of his will, and he wasn't being mandated to do that, right? So it also makes reporting or refusing to give appear socially, inappropriate. They will just label you as being stingy. So, I mean, these are some of the things that make it really difficult to understand this behavior. And also it's also a pointer to the fact that when it comes to, SBC, we need to be very careful and be a bit systematic about how we address corruption, particularly in institutions. Thank you.
Yeah, thank you so much, Malcolm. And finally, just to ask you before I move over to essay, one of the key things we're looking out for when we started this study was the place of intersection of social norms, gender norms, and faith norms. And so I would want to ask, as you wrap up your thoughts, what surprised you the most about the intersection of gender, faith, and then social expectations in the findings?
All right, thank you. I think for me, really, it's when we started out this study. So one of the things I was a bit, skeptical about finding these intersections or probably being able to link these intersections. For instance, the social multiple social identities, how they interact with each other to influence a particular behavior. So what surprised me the most is the depth of the gender double blind that we found in the study, especially for female health workers. And in other words, health workers, especially female health workers, are put in a position where any action they take is criticized or penalized, either in the community or in the facility, often because there are conflicting social expectations, that relates to how you should behave as a woman in the hospital, how you should behave as a woman in the community. For example, when you look at it, the gender expectation of being a caring and honest woman, and the social expectation from the community from the health facility that you should have for informal payment, you could see that these are conflicting norms and social expectations. Another example is, faith expectation of being pious and generous at the same time. If you are expected to be generous, right? In the community, many health workers will find ways by which they can ensure that they fulfill this role and obligation, right? The other thing that surprised me is how well health workers adapt to these conflicting norms. So it is contextual. Health workers are not passive. They engage in this behavior, but they look for subtle ways when there are conflicting norms. They look for subtle ways, to ensure that this behavior is practiced. So two things, right, is how they adapt to conflicting norms, and then the depth of intersections that we found. I'm sure that many of these intersections are well outlined in the report, and people can go to the report and read more about it. Thank you.
Thank you so much, Malcolm. And this is also to remind us that the link to the report, and I think one or two other blogs that were written as a product of this study, they're all attached in the comment section, so you can just find it and download. I would move over to essay now, because essay played a pivotal role in this work. covering the aspects of gender, as well as seeing how this study can be used practically. So key thing for us was the practical implications of our study. We wanted to see how the findings of it practically, especially for anti-corruption programmers. So let's say, let me put you on the spot. If you were to design a program that would be, what would be your intervention points, especially something that has to do with anti-corruption, primary healthcare sector, and all of that?
Okay, thank you so much, Isaac. And also thank you to Mayoko and Busola for the explicit, presentation of our findings. So first of all, I would think that the first intervention point should be for health workers. And interestingly, the report also, agrees with that as well. And the reason being that health workers hold significant power in the informal payment dynamics. They are the gatekeepers to care, and they are the first point of contact and all of that. And also to point out that they are deeply influenced by institutional expectations, gender expectations, and also community expectations. So it's important that this should be the first point of call if any programming needs to be done at all for anti-corruption. Engage them directly. Also to consider the fact that regardless of the fact that, they are involved in all of this, any programming should also put into consideration, the structural fixes that have been identified, such as poor salaries, in quotes, such as, unavailability of commodities as well. So while engaging them, while, thinking around programming for them on anti-corruption, all of these things should also be considered as well, since some of these things also reinforce, most of the norms that we have already talked about already. So I think the first point of call should be for health workers. Thank you.
Thank you so much, Essie, and I'll still stay with you for a few more minutes. So it was really important that we highlighted the structural fixes, improvement of salaries, provision of supplies, and all of that. But one interesting thing for me was the report also warns against relying solely on awareness campaign. Why do you think that was, and what should we be looking at?
Okay, so when you talk about awareness campaign, you're trying to raise awareness, let people know, oh, this is wrong. But sometimes if you are not careful, it could lead to normalizing the practice of that particular issue that you are raising awareness about. So what the report suggests, instead of just awareness campaign, so the report suggests that, strengthening oversight and accountability mechanisms. And what do we mean by strengthening oversight and accountability mechanisms? It means that you could initiate a system where there's transparent billing, okay? So everybody is aware that, when you go to this health facility, this is the recommended billing. So nobody is working in ignorance, nobody is being, kind of deceived, sort of. Everybody is aware. And then could also involve the WDC, that's World Development Councils as well, and involve them in the process. So everybody is being held accountable. And then one other thing that could be done is institutionalizing fair payment structures, such as facility-wide pooling of charges. It reduces the need for individual solicitation, because that is where it usually starts from. So if there is an existing fair payment structure, so it becomes difficult for an individual to ask for this informal payment, and everybody is aware of it. And then just to add also, types of intervention that would work here is also looking at the gender component as well, engaging both men and women differently, because this whole informal payment dynamics affects, both genders differently. Thank you.
Thank you so much. And then finally, I would like to ask, I know you said it affects male and the gender separately. What would be the gender consideration programming?
Okay. So looking at it from some of the findings that have already been mentioned, we have, talked about how men feel pressured as breadwinners, to provide for their families and all of that. So talking about programming for men, we would suggest that could create safe peer networks where integrity is redefined as strength and not weakness, okay? Dialogues around healthy masculinity, and to state that healthy masculinity values fairness, it values transparency and service. So it should not be equated to, being weak, that as a man, you should be able to say no, to things, and people define it as strength and not as weakness. So that's for the male gender. Then looking at female gender as it is, so my colleague mentioned the double bind. Okay, so sometimes women are expected to be compassionate and nurturing, yet sometimes they can also be pressured to provide financially. And also looking at the fact that we talked about women not having sometimes the ability to refute some of these informal payments, when they are being requested for. Yeah, and all of that. So it's something that should be considered, when doing, your programming. So how do we ensure that women are able to, have the ability? And we can do that by conducting awareness building among women, not just to inform them of rights, but also to give them, the ability, build that confidence in them, and also you can also create a kind of channel, an anonymous complaint channel that will encourage women, to lay their complaints in case they are feeling too shy or because they are being expected not to report. So we could have anonymous reporting channels and, have all of that sorted out. So I think I will stop there. Thank you.
Thank you so much. Thank you for that. Okay, so we are done discussing the findings, and I would want to mention that if you have any question, you can please just drop it on the comments while I give Diana just a minute to wrap up some of those interesting thoughts she had based on the study. Diane? If you can hear me, you're muted.
Yeah, here we go. Sorry about that.
Yeah.
Thanks, Isaac. And I want to leave as much time as possible for questions and discussions. So I'm not going to say very much. I think one of the reasons that, as Cheyenne said at the beginning, we undertook this, and you can see the richness of the findings out of the study, was to really look at, we've tended to look at social norms by themselves, or the institutional solutions by themselves, or the gender norms by themselves. And I think what this study has shown us is that they really interact with each other. And so we need to look at it much more holistically and address it much more holistically. So part of what I take away is really looking at that and thinking through, how does this apply to different segments of our interested population, and how do these things interact so that we can be having a more complex programs, but also cooperating across different fields and different programs more effectively. Because, and I think Mayokun said this, I mean, what's at stake here is access of people to healthcare. So the impacts of all of this on people's access to healthcare and their ability to, sort of have good health are pretty profound. To turn back to you, Isaac, or to Omo to get questions. I definitely encourage people to put them in the chat, but I'll turn them back to you because I think the fun part will be having discussion.
Thank you so much. We're also looking out for questions. We've not had any, and Omar reached out to me. So please, if you have any question, you can reach out or send them to the chat. I I don't know. Okay. So there is this question: is there a whistleblowing legislation in Nigeria? Is there whistleblowing legislation in Nigeria? I think I'll pass that on to Mayokun. Of course, there are legislations and things that make sure the primary healthcare centers are transparent. And I remember when being on the field in Kano, we saw some of those stickers that speaks to do not give bribes, do not take bribes, and all of that. And that's the crux of what we're talking about when I say mention that don't just rely on awareness campaign, because all of that just, lies solely on awareness, creating awareness about bribery, taking bribes and giving bribes. For us, it's beyond that. Michael, would you want to speak to that?
Well, I think straight to the person's question, which is really around if there is a whistle blowing policy. Yeah, so of course, I know that there's a whistle blowing policy, but I think it's not much of whether this policy exists or not. I think it's really around even what happens afterwards, right? Because what we are seeing from the study is that some of these things are normalized, right? So whether the person blows whistle about a wrongdoing, a corrupt practice somewhere or not, really does not matter as much as ensuring that corruption is not normalized, because if it is normalized, if the person blows whistle, I mean, for all you care, nothing is still going to be done. And we are looking at it even from the prevention side of things, right? If you want to prevent, if you want to curb corruption, really, you have to think about multiple or a holistic way of addressing corruption beyond the traditional strategies that we are aware of. Thank you.
Thank you so much. Diana, do you want to speak to that?
And I can't say that I know specifically about whistleblowing. There are probably people in the participants in the audience now who probably know more about the whistleblowing legislation, but I just highlight what Mayokun is saying is that it's likely, and I think some of the findings of our research support that also, but we've seen it in other research that social norms also affect people's willingness to blow the whistle. So even if you have very robust legislation, it helps, obviously, so you need it. But you also need to work on people's willingness to blow the whistle, because they often suffer really bad social consequences if they blow the whistle. And in this case, with the gender sort of dimension to that of not being confrontational, not clear that the whistleblowing legislation will solve the whole thing, but I think you need to look at it holistically.
Thank you. And I think there's another question that says, is there consequences for being found guilty of corruption? Of course, there are consequences if found in Nigeria, big consequences, and depending on what you're talking about. But I would want to read out the next question, and probably to Malcolm as well. Are there opportunities for health workers are there opportunities for health workers to report corrupt actions or corrupt doings without fear of reprisal attacks? And that's when we're talking about the sanctions. Okay. So Malcolm, would you want to speak to that? And then are there plans to conduct an awareness to health workers? I'm sure we can take that. But the first questions.
All right, thank you. So I think it's to boils down to what the response Diane gave the other time, right? If there are opportunities for health workers to probably report corrupt practices in their facilities or that they are aware of, the truth of the matter is that, of course, because of the fact that it's normalized, nobody sees, any wrongdoing in that, right? But then you that have probably reported it or probably, pointed people to the wrongdoings that are happening in the facility, you are likely to, face reprisal attacks, backlashes. And that's exactly what Diane mentioned the other time. For instance, they consider it a bit abnormal or out of place for a female worker to probably, whistleblow a corrupt practice that she probably noticed, right? Simply because she's going outside of her gender role of somebody who is supposed to see things and then keep mute rather than speak out, right? So once you are doing that, there are tendencies of sanctions, and those sanctions are subtle. Say, for instance, you get transferred to a very distant place, and I've seen cases like that when people they will just label you as somebody who is difficult to work with, and then you are transferred. So that these are things that creates these complexities and bottlenecks when it comes to tackling or curbing corruption, even in health facilities. So they won't tell you that the reason why they are punishing you is because of the fact that you whistleblowed or something, right? But it's because of the fact that they are shocked by the fact that you are challenging, the norm, and people don't like it. So these are some of the challenges that we face, and we found that strongly in discussion.
Thank you so much. That's also mentioning the sanctions that health workers come out to, report these cases face. Sometimes harsh, and then other times very passive. Stella, I think you want to speak now.
Good evening, everyone. I want to appreciate everyone who made this research possible. To say that this is actually a very endemic area as far as we as the people is concerned, and the fact that your organization has been able to take a dive into this issue is very commendable. Looking at the gender dimension, you find out that even in the primary health care, the women, are the most affected, because women barely have what it takes to even, pay for or access whatever healthcare they want to access. And then you find out that there's something I would call double payments, because most times the women people have to actually pay what the actual fee for accessing a particular health care, and still have to pay to the charlatans that are within the healthcare system some form of payment that goes unrecorded. So you find a lot of double standards in terms of where what is being paid officially for, and what is paid for unofficially. And then the question is, it becomes so worrisome, because sometimes when you go into the health system and then you pay, even when you pay the official thing you're supposed to pay, and you don't pay, and you don't get to pay the unofficial things, you will not be attended to most times. They might look for a way to delay your treatment, or make it very difficult for you to assess what you're supposed to assess, especially as women, probably even in the maternity situation, where a woman needs to, she needs to be cared for because she's pregnant. A lot of bottlenecks are put on the way. I think I also see the need for intersectoral approach to all of this, but I don't know how that has worked, because the accounting system in the healthcare facility, most times, I think in the government setting, they get people from the Ministry of Finance, sometimes to man the desk. But you find out that when these people come in from probably the Ministry of Finance, they meet a culture already in place. And in as much as there's a culture in place, no matter if that person needs to survive there, is either abide by the culture, or you'll be sent back. Some kind of they'll cook up some kind of stories about how inefficient you are, and they send you out of that place. So I don't know how we are going to handle this, especially with the new tax reform, because I think it is a clarion call for government to know that Nigerians are double tasked at every point in time. It's not just the official tax we pay. The unofficial tax sometimes can be even above the official one we pay, because somebody needs to get some money off you, because they know you're desperate to get something. So I don't know how we can either approach it from the intersectoral dimension to get in the FIRS to understand that a lot of double taxation is going on in the healthcare system, so that they come in there and see what they can do. Get the Minister of Finance to come in to understand that Nigerians are double tasked. And it's the double taxing that is even making even the official one look too heavy and a burden on especially women, you know.
Okay.
And sometimes
Thank
the religious institutions, they look the other way because somebody somewhere is living fat on it.
Yeah,
Thank you so much for this great intervention. I think going forward, organizations should pick up some of the things we need to. A lot of intervention should come from these findings in terms of programming and all of that. Thank you so much.
Yes, thank you so much, Stella. I will be excited if you also you're able to download the reports and then read some of the findings there. I'm sure it just captures a lot of what you have mentioned and what you have said. So 2 more things and then we wrap up. We should be finishing in another 5 minutes.
I think as a summary, so we found that behavior is complex, right? And so for social norms experts as well as anti-corruption programmers, so it's really important for us to take into account the interaction of multiple social identities and social expectations that influence behaviors, right? Because they make it a bit more complex for us to, when it comes to, designing interventions. And most times, programmers are blindsided by these, intersections, right? So it's important for us to take all of this into account, particularly when we are diagnosing behaviors. That way, we properly be able to, develop and design holistic interventions that would help us in, curbing corruption, as well as also when it comes to social norms intervention, replacing negative and harmful norms with positive ones. Thank you.
Thank you so much. And thank you everyone for your comments. Parents, wow, I see your comments here which says, I would equally add that corruption has no gender, morals and virtues, should be the social compass, structural reforms and transformative ethics should be intertwined into workplace moral and virtues. Thank you for that. Diane also said, to answer questions about how awareness campaign alone might encourage or reinforce corrupt behavior. First, if there are social norms at play, awareness but won't change the social pressure people feel. Second, there is research on awareness attention to how prevalent the behavior may make people more cynical that anything can be done, and that is they feel everyone is doing it even more than is reality. Thank you everyone for your contributions and for interacting with us on the study. To close us out, I would like to ask Dr. Sasi Dirisu.
Yes, it's been an amazing time just listening to, have everything come together and just listening to everyone speak in the last hour. I think all the findings and the learnings from this research, we all collectively agree that as we continue to disseminate these findings, that they would really make a difference in helping policymakers and implementers rethink this conversation around corruption in the health sector, and also building innovative approaches to addressing them. I just want to thank everyone who has made this possible. I know that Cheyenne had done that at the beginning, from our funders, from our partners, from our wonderful colleagues at BESA Global, our wonderful brother from Makerere University, Paul. Thank you so much. Thank you, Diane. Thank you, Cheyenne. Thank you so much to the wonderful PIC team, communications, all the people who provided some information, either as research participants in the sense-making workshops, the co-creation workshops, all the dialogues. We truly are grateful for everyone's contribution to making this possible. And we just ask you to take advantage of all the resources that have been shared to just immerse a bit deeper and then ensure that we can translate these lessons into implementable opportunities for social impact. Thank you so much, and have enjoy the rest of your day.